Thank you. Hi, everyone. First of all, I want to thank to kind invitation from organizing committee. And I have asked to cover this topic besides the aneurism talk. As you know, everyone is agreed that time is brain. No doubt about that. When you look the past, our neurologists all around the world need some clinical strong evidence to give the patient to endovascular treatment. Actually, the evolution of endovascular treatment techniques and materials doesn't let them convince themselves on stroke. But it is changing right now. The winds are changing. Now wind is more warm coming from south, not from north, because of the new clinical trials on stroke. When you look the first IV RTPA treatment in 1996, the time limitation on those group was 3 hours. The European study increased the time to do 4.5 hours, but FDA not approved that 4.5 hours. Most interestingly, those studies excluding high-risk patients, so-called 80 years old. NIH score is around 25. Also the history of diabetes and stroke. Actually, majority of those patients has diabetes and stroke at the same time. Why you are excluding those cases? Those cases also get really big benefits from acute stroke treatment. So the questions appeared after years that IV RTPA treatment is really not good for large vessel recanalization. These are the general recanalization rate of the vessel segment. The best one is the M2 segment. That means above the bifurcation is 44. When you go down to internal carotid artery terminus, is go down to 6%. And everybody is also agreed that there is a very strong relationship between recanalization rate and neurological recovery. Everybody agrees on that. And another one, we learn to check our patient for long-term real clinical examination, which is MRS score or Bartel index. So, do that IV treatment really recanalize the occluded vessel, or it is really helpful for opening collateral vessels? At the same time, we have an opportunity to use our MRI system to understand where is penumbra and where is the umbra. But in a very acute stage, nobody really knows that particular case has really good collateral flow or not. You know that the brain has a big capacity on collateral flows. This is a case of me. There's a chronic occlusion of bilateral internal carotid artery. This is left side. See the retrograde ophthalmic collaterals from external carotid artery fills the internal carotid artery. When you look to the right side, again the internal carotid artery is absent. And look at that, occipital arteries, transosseous, transdural, the transarachnoidal anastomosis feeding that part of the brain. And when you look to vertebral artery injections, PCA, MCA branch, pile collaterals, really having a good feeling of the MCA territory, this patient has only slight headache, nothing at all, no infarction. When you look this case, another one, when you look carefully, you may see some vessels around enlarged, but that's all, nothing. When you give a contrast material, you have an abundant pile contrast enhancement. When you go further, actually you may understand that this is a moya disease, actually activated all the pile collaterals. Okay, we already know that in a chronic phase, we are creating good pile collaterals in certain cases. I'm not talking whole. Also, we are using this potential in aneurism treatment last 25 years by occluding the parent artery. As this case, this is 7 years before, is a dissecting aneurysm becomes a serpentine type of aneurysm. This is at the beginning, that small dot, and this is right now. And then when you occlude the parent artery, in majority of the cases, you have no infarction on the distal territory. We know that. But we are talking this risk to the patient and patient family before deciding it in most of the time. So, if we have such potential to create collaterals, how can we understand that the particular case has a large vessel occlusion with a collateral flow? Clinical evaluation alone is not enough for it. It is proved. But radiological examination improved a lot. And we're getting far more fast imaging protocols, especially with new MR system. It doesn't matter that we haven't got such system, but in the future, and the majority of the world can able to do it. But we have other simple techniques like Doppler ultrasound or CT and MRI, congenital. And when you look the numbers of prediction of large vessel occlusion, and actually if the patient clinical status worsened, you may say that the patient has a large vessel occlusion without any clinical imaging. So, in summary, NIH-SS score is not enough to prediction of the large vessel occlusion. If it is deepened in clinical findings, the time is already passed for acute treatment. So how about the mechanical recanalization rate? Effective recanalization rate can be classified in the TK3 or TK2B. After having stent retrievers and aspiration devices, especially stent retrievers, we have significantly improved recanalization rate. When you look the drug recanalization rate in PROACT-2 trial is around 20, and also the internal carotid artery terminus is excluded. And we have Mercy and the former Penumbra aspirating device. They all increased that number. When you got the stent retriever like Solitaire and Trevo, it's go up to 60s at the beginning. When you look to randomized clinical trial the last 10 years, MIS3 synthesis or MR rescues, when you look in summary of those studies, they are looking at AV, intraarterial intravenous versus IV alone. Less stent retrievers, they use it. Only 5 of them in the first one. Only 13% stent retrievers. and really this is the reality, and no imaging data, especially in synthesis MRSQs. But even though they have a less recanalization rate, there is no failure of endovascular therapy on those groups. And then this year we had very important results of that 3 clinical trial, Mr. Clean, ESCAPE, and Extent A. When you look in details, there is no age limit in those groups. And you can see the 6 hours period. They all use stent retriever. They all use stent retrievers. And they combine the technique with vascular imaging. All trials had a fantastic recanalization rate up to 86%. And then the results also very good. All trials shows improved functional outcome in all age group, not excluding the elderlies, 80s. When you look at the meta-analysis of this prospective randomized trial, it is obvious that when you combine with endovascular arm, you have superior outcome in large vessel occlusions. It's obvious. It is not clear in posterior system. All these trials is anterior circulation. The basilar artery posterior system need to evaluate with randomized clinical trial. Still, we're waiting for it. Main factors affecting that nice results is actually onset of the treatment, of course, and selection under the guidance of neuroimaging, clot characteristics, also the decision time. The patient can able to reach the hospital, but the decision-making process may be slow between neurologist, us, or whatever. Fast recanalization can be done right now with stent retrievers or large bore aspiration catheter. It is available right now. So after those trials, that 3 trials, stroke organization, European Stroke Organization, and the Karolinska Stroke Update with ESMINT group release a kind of protocols or wishes in stroke conference in Istanbul. And because we started to have the strong evidence on those groups, I want to go it quickly. I don't want to take your time, but even with 4.5 hours, mechanical thrombectomy plus IV thrombolysis has a very good success and has a good level of evidence in our hand. Those numbers are the southern winds in this group. And the mechanical thrombolysis should not prevent indication of IV thrombolysis where it is indicated. So there should not be delay in the emergency the department on giving IV thrombolysis. You don't need to wait for it. A simple examination of the brain, and then without delay, it is better to start it. And now the stent retrievers is an important tool. We should force our local authorities to cover the expenses of this treatment. In Turkey, for example, we have problems for it. They still don't understand what's going on. So it's going like that, and it is in favor of mechanical thrombectomy, additional to the IV thrombolysis. Again, the same for basilar artery occlusion. and the multidisciplinary approach is there, and experience is important, but experience centers still has lower level of evidence in that published literature. And also the trained interventionalists and the choice of anesthesia is open to discussion, but the aim is not to lose the time. It all depending on the team's technique. And the patient selection is really very important to understand the size of the infarct, to understand the penumbra affecting your results. And if you haven't got an imaging technique, as I told you at the first slices, you may go for an IA score at the beginning to understand the patient has a large vessel occlusion or not. But anyhow, when you talk the imaging techniques you have got, and when you talk you should be quick. How can we quick for it? Most of the hospital has radiology department away from the neurology department and away from the angio department. How can we be so quick? And another important thing, high age is not a restricting factor. In summary, recommendation of those group is we should do the other trials for basilar artery occlusion, and we should do treatment in the late or unknown time windows because of the potential of collateral flows in the brain. And treating patient with imaging findings not sufficiently covered in this recent trial, we should improve this imaging technique. And new devices additional to the stent retrieval is necessary to check for clinical trials. And in Glasgow in April, other trials reported. It is Swiss Prime and Revask, as mainly they use solitaire stent. And the same results, a little bit better results than the further one. And so it seems that we are improving ourselves in terms of clinical evidence. I want to show you some technical ability we have in our hands. I did this case 5 years ago. I did treat this aneurysm with the pipeline device without giving contrast material, just by using the MR angiography overlaying technique because of the kidney problem. And we have an ability to see the perforating arteries in the brain. This is the VASO-CT or flat panel detector CT. After the basilar artery stenting, you see the basilar artery perforator clearly. We will use such knowledge in the future. I'm not saying that we should use in every case. This is the image from the patient. This is the image from the atlas, famous French writing atlas, showing the perforating arteries. Do you see any differences? This is in vivo. This is the atlas after autopsy. So, in conclusion, after having a good acceleration rate in developing endovascular tools and imaging facilities, and new encouraging randomized clinical trials, by the help of fast imaging technique in radiology department and the so-called expecting hybrid systems in those techniques give us a chance to treat our patients more properly. Thank you for your attention.